Welcome to Around the Room, brought to you by the Canadian Rheumatology Association. This episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Let's all think back, if we can, to when we were 16, 17, 18. What else was going on in our lives? So yes, we have this chronic illness that requires regular medications, probably injections that you are fed up with, having to get blood work done routinely and other things like eye tests and lots of appointments. So now let's layer on the usual things that a 16 to 18-year-old is going through. There's a lot going on.
That's Dr. Michelle Batthish. She's a pediatric rheumatologist at McMaster Children's Hospital in Hamilton, Ontario, and associate professor of pediatrics at McMaster University. Her clinical and research interests include healthcare transition in patients with chronic rheumatic disease and quality improvement in pediatric rheumatology. She is also chair of the Transition Working Group at the Canadian Rheumatology Association, amongst other significant roles. We're happy to have her as our guest on this episode of Around the Room, talking about transition to adult rheumatology. Welcome to everyone. I'm Daniel Ennis, and I'm joined as always by my co-host, Dr. Janet Pope. Good to see you, Janet. How are you?
Good. How are you, Daniel?
Well, I'm all right. It's nice to talk to a Hamiltonian because I'm from Dundas, which is just around the corner. So I'm really excited about our guest, Dr. Michelle Batthish. Thanks so much for coming on the podcast.
Thanks for having me, guys.
I'll do a little bit of table setting here because this, I have to admit, this is not an area that I fully understood as a problem, and I'm sure you'll educate me more. But just for listeners, transition care in pediatric rheumatology is a critical determinant of long-term outcomes for patients. However, according to the 2022 CRA position statement on the topic, around 25 to 75% of youth with rheumatic diseases experience a gap in care or are lost to follow-up after transition to adult rheumatology care. And this is especially concerning since up to 75% of these patients will require ongoing treatment and monitoring throughout their lives. There's something fundamentally different about this transition of care compared to the standard transfer of care we may do routinely in practice. So maybe to kick things off, I'm curious, when you talk about healthcare transition in pediatric rheumatology, what key elements distinguish it from a simple transition of care?
It's a great question. I think it's good to start off with just some clear definitions. So when we talk about transfer of care from a pediatric rheumatologist to an adult rheumatologist, that really refers to one point in time when the care and ongoing follow-up really just moves from a pediatric rheumatology clinic to the adult rheumatology clinic. So it's just, again, a one point in time transfer, almost like an administrative transfer of care. So health records may be shared and so on. Healthcare transition is considered more of a process and is beyond just a one point in time event. Often we start the concept of transitioning to adult care in our patients as young as 12 or 14 to start preparing them for this idea that their care will eventually be followed into the adult healthcare system. We also use this opportunity to help educate and prepare the caregivers because they also go through a transition period during this time. And so, as I said, starting as young as 12 and 14, we start preparing our patients in learning more about their disease, their medications, how to self-manage their condition. And that takes time. So we start early, and throughout the several years until they turn 18, we continue to prepare them. The other thing is that transition doesn't end once the transfer has occurred at 18. We all know that 19, 20, 21-year-olds are still developing. Their frontal cortex is still not fully developed beyond probably until 25 or even later. And this kind of ongoing preparation and support that these youth needs to continue beyond 18, well into their 20s.
There's quite a bit of literature around sort of transition readiness, and you mentioned that you start the process quite early. There's different phases of transition, but how do you identify when a patient or a patient's parents are actually ready to transition or ready to begin that process? Does everyone start at the same mark, or is that a fluid process early on?
It's very fluid and it's very variable based on your patient and their age, their sex and gender, and caregiver involvement. There are a lot of great tools that have been validated in pediatrics, so in rheumatology and in just general chronic conditions that can be used to assess transition. So it doesn't really matter which one you choose, but I think assessing transition readiness regularly early in their teenage years up until they've transitioned is really critical because it can help identify the gaps that the youth may have in understanding their illness and taking over their own health care. And we've shown that transition readiness varies greatly across patients, obviously across ages, and that we would expect as you get older, you mature a little bit more. And so you may be more ready for transition. But we still see some 17-year-olds who score much lower on a transition readiness scale compared to a 15-year-old, right? So not every teenager kind of matures and develops at the same rate. The other thing is that we've also identified differences within the age group. So not every 15-year-old is at the same stage. And then finally, there's been evidence to show that boys or males may have different readiness scores compared to girls their same age. All this to say, I think, is just to highlight the fact that we as care providers need to be flexible and provide more of an individualized approach to each
Hmm.
youth slash parent kind of caregiver, and to then apply and help them get ready for that transition period and identify that maybe this patient may need more help understanding their medications. Meanwhile, this other patient may need more help to be a little bit more independent in asking questions and going to their appointments on their own. The other gap in the literature right now is assessing readiness in the parent and the caregiver. So there is nothing right now out there to be able to objectively measure readiness for transition in caregivers. And I think that's can be quite a valuable piece of information to have because obviously, as youth go into the adult system, the role of the caregiver becomes less and less. And so we need to be able to educate and support these caregivers to let go without them feeling left out of their child's care. So right now, our group at McMaster is currently working on developing and validating a parent transition readiness tool. And so hopefully that will be something that can be used in the future.
That's really helpful. I have a comment and a question. So my comment would be that when children have been sicker, at least in my experience, the parents' readiness is far less than say if it was a posse or articular little one who now has grown up and is ready to transition and they were never super sick or it's been a long time before there was a lot of new interventions going on for that kid. So my observation is if there was a sick child with lupus as they become a teen who's really had a struggle, that I think it's really hard for the parents. I can't tell you about the kids because the kids who show have more readiness than the kids who don't, who become no-shows. So that's my comment. And then my question around that is, I don't know if that's been your experience or this, I'm just doing like one-offs in my brain right now. But also, in general, would you do a readiness for each child along the way and look at their measures over time?
Yeah, so I think your observations are common. Knowing a child who's had very serious illness, who's maybe even been hospitalized, their parents have been heavily involved in their care at a young age. And so they carry so much of that health knowledge about their child with them. And so it definitely can be harder for them to slowly let go. The other thing that needs to be considered is at what age was that child diagnosed? So there are kids we know that we can diagnose an oligoarticular JIA as young as 2 or 3. And so we've been now following them for 15, 16 years. There's also more of an emotional attachment to the rheumatology team. So that can also be difficult for the caregivers to let go, even though if their child may have had a more mild clinical course.
I'm curious that this may be a silly question, but Is a lot of this problem or this challenge of transition, is a lot of this like an artifact of sort of the administrative cutoff of 18 years? So at 18 years, you really do have to hand them over to adult rheumatology, but their physiology does not jump at the age of 18 to 19. That's not what's happening. And some of these patients, as you've articulated, some of them are not ready, despite all of the good work of a multidisciplinary team. The problem is still actually quite enormous, right? Like up to something like 50% are lost to follow-up, which is astounding. Is this a problem that would be fixed if they stayed with the rheumatology team for 2 more years, 3 more years, and then this would be erased? Or is this going to be a problem regardless of when the patient is transitioned? It will happen around this age no matter what. And I'm curious what you think about that.
I think it's probably a little bit of both. Why 18 seems like a pretty arbitrary number. It's not like kids magically turn into well-established adults who know how to live their life and manage their own lives, even beyond their healthcare, like their finances and their education and their jobs. So absolutely, I think if the system was built around the kind of physiologic development, as you mentioned, of when a teenager or adolescent truly is ready from a development point of view to transfer from a pediatric to an adult care setting, that definitely can be of help. So one way to mitigate that centers have done is have a young adult clinic. So even though after 18 they technically leave the pediatric center, there are clinics across the country that will follow those 19 to 25-year-olds. And the models differ. So often it can be a combination of a pediatric and an adult rheumatologist who will see them together. And then when the team deems them truly ready, then they can then transfer them over to just a regular adult clinic. I think it can also help the youth because they're moving from a pediatric-friendly hospital. There's cartoons on the TV, coloring books everywhere. They feel like they've outgrown that kind of center. But at the same time, they move to an adult clinic where they're sitting in a waiting room with people who may not look like them either. And so if they're now waiting to be seen in something like a young adult clinic, it might also help them feel more comfortable, attend their appointments, and be able to speak openly to their new caregivers.
So you've started to articulate to us kind of some of the process. I'm curious if we can get a little bit more granular on how do you actually begin the transition? What are these conversations like? And what sort of tools do you work on with the patients to get them ready for booking and keeping appointments, keeping track of their medications and filling scripts, getting their blood work done? Some of the basics of attending adult appointments that, in the absence of a multidisciplinary team, we may not have the resources to remind them about or coach them on in the same way.
So there are different models that exist. And right now, we don't have evidence that one model is any better than the other. I think just the concept of having a transition care model at your center is excellent. So I can explain our experience here at McMaster. And again, there are multiple other multidisciplinary transition clinics across the country that do wonderful work. So at McMaster, we start at the age of 14. And any one of our patients who we anticipate needing adult rheumatology care will be booked at least once a year in our combined transition clinic. So this is a multidisciplinary clinic that runs twice a month with 2 different adult providers. In this clinic, they meet with the new adult rheumatologist as well as their regular pediatric rheumatologist. Of course, we have our nurse at the clinic. And then we have a child life specialist who will meet with the patient to go over transition readiness. So how that's done is we use a tool called the transition queue. This is developed and been validated across multiple conditions, so it's not rheumatology specific. And what's nice about it is that it's available on an app for free called the My Transition app. So youth are encouraged to download the app for free if they're able and complete the questionnaire on their app, or we have paper forms as well that they can complete in clinic. And the questions range from simple things like, I can ask the doctor questions, or I can answer the nurse's questions. I do my appointment by myself, all the way to things that maybe require a little bit more maturity. Like I fill my own prescriptions. I arrange to get to my appointments by myself. And the score then is calculated out of 100. And so the higher the number, obviously, the more ready they are. What the child life specialist does with this information is they will then select one or two questions with the youth that they may have answered as I don't do, so never, and will then work on some strategies and tips so that they can go from never to sometimes by their next follow up appointment. Associated with each of these questions are tip sheets or hacks that we have for these youth. Let's say they've identified question one. I answer the doctor's questions by myself. There's associated tips that will help both the patient and also give tips for the caregiver to promote this with their child for their next appointment. So we track these scores over time, so we're able to then slowly ensure that they are ready. And if we feel that we're stuck at a certain barrier in their care and their self-management, it's a signal that they may require more work or more encouragement, more education, whatever it may be that we'll identify. So as I said, usually when they're on the younger side, 14, 15, we'll see them once a month. And as they get older, closer to beyond 16, 17, almost all their follow-up is in this transition clinic. So that by the time they're 18, they have met the adult rheumatologist multiple times and may feel a little bit more comfortable seeing them. And the adult rheumatologist has now been a part of their care for some time. So they also feel comfortable and know what their disease trajectory may be like, what medications have worked in the past or what hasn't. And then at that last visit, it becomes very seamless so that their follow-up appointment in the adult rheumatology clinic is booked together and they have all their contact information, and we hope they show up and the follow-up ensues in the adult service.
So that sounds like a very holistic approach to getting someone ready. What if someone does not meet the outcomes that you want by the time they're 18, or even if you hold on to them a bit longer? Presumably at some point, even with the additional training that you give them and all of that kind of teaching that you do, there may be some people who aren't quite ready yet. Are you able to elaborate on what sort of happens for those patients?
Yeah, it can be quite challenging. One solution you alluded to is we are able to continue to see them in our clinic, in our combined clinic for a little bit longer beyond 18, especially if some of our patients may have more complex medical issues, some developmental delay, and so on, with the caveat that if they need emergency care, they have to go to the adult hospital.
Hmm.
For those either beyond that or at 18, we have to then transfer their care. It is at least a signal for the adult rheumatologist that they may need a little bit more time, reminders for appointments, whatever it is that they may be lacking from a transition readiness point of view. Appreciating that it can be very challenging because adult rheumatologists aren't as well resourced when it comes to allied health providers or several nurses, a social worker, whatever it may be. So it's definitely a challenge. One model I've kind of entertained in my head that I think would be really cool to try out, but again, will require some resources, is for the pediatric rheumatologist to then join the follow-up in the adult rheumatology clinic and for them to tag along to those appointments. That's something some of our patients have said after they've left. They'll say, why did Dr. So-and-so come to our clinics on the main floor in the pediatrics clinic for so many years, but Dr. Batthish hasn't come up to see me up in your clinic? So it's an interesting idea and it's something I probably would want to pursue. I just have to think about the logistics and what that would look like, and maybe then get some feedback from our patients to see if it truly is it more just like a piece of comfort that there's someone from their team. Does it really have to be me? Could it be the nurse? Could it be our child life specialist? So it's just an interesting thought.
It's probably too because they do have to say goodbye when they come to the adult world. If it is something that we will follow long term, we have them till we retire or the kid move, young adult moves or something. Whereas they probably are very attached because it was the fear at the beginning. They sense their parents' fear or the caregiver's fear as well. And now, hopefully, as they're transitioning, they're better. And sometimes they are, and mostly they are, but they aren't always. So I think it's probably the comfort thing. And you're right, it could possibly be resolved in various ways. So for all these clinics that exists. There's not that many YARD, the young adolescent rheumatology type clinics. Is there any data that, say, if we're in a center where this isn't going to exist, that the pediatric room can be with the adult room, and then that adult room is the one that takes them on because the kid might be going to school elsewhere, they might be in a smaller site, etc. Is there any data that if we do the UCIC, that there's more likelihood of them then attending when it's you no longer see and we see? Because we've done that sometimes, I hear, but I like, as Daniel said and you mentioned, the no-show rate, if it's a cold call kid where I haven't met them before, is very high. And it's frustrating because then we try to track them down and it's very difficult to do.
Yeah, so there isn't evidence to show one model leads to fewer no-shows than the other. So as you alluded to, there are different models. So there's the type of model where they're seen by the pediatric rheumatologist, maybe at around 17 and a half. They go to the adult rheumatologist, get to meet them. And then they have what we call a boomerang visit, where they come back to us to check in. How'd it go? Did you guys connect? Were you okay? Are you happy? And then do the final transfer, versus the type where we do at McMaster, where we see them in combined clinic and then eventually they're with the adult. What we did show, though, in one of our studies, when we followed the transition cues over time and their follow-up over time, is that we had a lower loss to follow-up rate in our model when you compare it to those already or previously published from, it's probably 15, 20 years now in terms of the data. So there is some slowly growing evidence to show that some form of transition, it's not to say that our model is better than others, but some form of transition may lead to less loss to follow-up.
I think I've jumped us ahead because there's a question that just came to mind that's super fundamental. It's almost obvious. What's the problem? What are the main things that patients report are the reasons that they don't continue on with an adult rheumatologist? Why aren't they attending appointments or responding to messages from the adult clinic? What is the major barrier here? Because I think probably a fair number of our listeners will be adult rheumatologists. And so I'm sure that they're interested in more practical tips for, like, okay, as a community rheumatologist, what do you want me to do? How do I help? Because I'm not mean. I have a great nurse. We run a great office and everyone's happy here. What's so terrible? But I think maybe we need to understand, as the adult rheumatologist, what's the problem? What am I doing? How am I doing this wrong? Can you elaborate on that a little bit?
So actually, it makes me think of like the "it's not you, it's me" kind of thing, right? So
Yes,
it's not
I've heard that a lot. Yeah.
right? It's not you, for sure. But let's all think back, if we can, to when we were 16, 17, 18. What else was going on in our lives? So yes, we have this chronic illness that requires regular medications, probably injections that you are fed up with, having to get blood work done routinely and other things like eye tests and lots of appointments. So now let's layer on the usual things that a 16 to 18-year-old is going through. They're graduating high school. They're making big decisions about their lives, right? Are they going to go into the workforce? Are they going to college? What university program? Am I moving away from my home now because I'm going to a school across the country and I have to think about my residence and so on? Financial decisions need to be made too. Do I have the financial support to go to university or college and all of that? And then we have to think about other things so now they're moving out of their home. Do I still have insurance to cover the really expensive medication? So that's the big stress, maybe more on the parent than the youth, but depending on the insurance coverage, maybe those are things that could be a source of stress. And then their own relationships, and maybe people are breaking up with their long-term high school sweetheart, or maybe they're developing new relationships and so on. So there's a lot going on in
Peer
this.
pressure too. The
There's peer
peers
pressure.
want to go out drinking, and
Yeah.
the young adult might be on methotrexate and was told, don't do that kind of stuff. Or they might have a whole bucket full of other comorbidities that require other meds, and they do get sick of them. Adults,
Yeah.
older adults get sick of their meds as well.
Yeah, Yeah, and so there are a lot of other typical things that any patient of any age will also be experiencing. And you're right, Janet. Can they drink? Should they drink? How should they drink when they're coming up with certain things they found on the internet or on some group chat that said maybe this is how you should drink to avoid potential issues because you're on methotrexate? Reproductive health becomes a big issue as well. They're having sex. Is it unprotected? Should it be protected? Obviously, it should be, but are there additional risks because they're on medications like methotrexate? So they have a lot going on. And so the idea now that in 3 months, you're not coming to the clinic you've always come to, you know where to park and you know where, you know, everybody there. You now have to drive to this other clinic that may or may not have the same team members involved. And it may be less of a priority for them, especially if their disease is well controlled. They may say, I'm fine. I don't need to make that appointment. I don't need to attend that appointment. Or they may say, you know what? My parents have learned to let go. I don't even know where to do my blood work. I'm on University Campus S. Where do I do my blood work? Or now my infusions have moved from a pediatric friendly place to an adult infusion clinic next to campus. So clearly, there's a lot of things on their mind that can potentially interfere or be barriers for them to then say, okay, I'm coming to my adult rheumatology appointment by myself. I know I need to do my blood work and I know I need to ask them for my prescription refill and so on. And so those things may be less of a priority to them, which then ultimately leads to potential negative outcomes in their health.
I think most adolescents at a certain age that in a normal maturity, they're invincible. So I think that doesn't help as well. Now, a question though, sometimes when I'll have a no-show that's being transitioned to, or I guess transferred in a way here in London, I'll look and it might be a young adult who has had multiple no-shows, and you find out that the support system for that youth has not been ideal, because often when you're 16 or 14 years old, it's not your choice that's making you be a no-show, it's the caregiver or lack of caregiver, etc. So I think that must be a red flag, because sometimes these are needy from their health. These young adults need to be seen, but it's when you don't really have a caregiver on their side, meaning the healthcare side of things, it must be a red flag, as this is not going to go well.
Yeah, and you would hope that at least on the pediatric side, that would be a flag that would have been raised as
Yes.
well to us, signaling to us again that they probably need that extra support. Maybe we'll help them learn where that new clinic is, depending on where it is. At Mac, we're lucky it's just 2 floors up for some of the rheumatologists that they see. Otherwise, it may be, you know what, let's make that follow-up appointment together. So we're in clinic, they pull up their phone and they call and make the appointment or book their blood work appointment together just to help give them that extra little support. And then hopefully, again, if we can start assessing parent readiness, that may also identify some potential concerns to help the parent as well appreciate that they may still need to give a little bit more support to their child once they've been transferred, to ensure, send them a quick reminder even though they're in a different province. Hey, honey, isn't it time for your blood work? Or do you need help finding a Life Labs near you, for example?
Janet, like you've had a lot of patients transitioned into your care. I'm curious if you have any other insights on where you've bumped into sort of pitfalls, or where your patients have been surprised that your clinic does or doesn't do this or
Yeah.
that.
So as a for instance, I would say the mismatch between the parent, especially as we said, a child, they're a young adult now, but when they were quite sick as a kid or long term in the pediatric area, sometimes I think mom is almost horrified that we get rid of mom. So we let mom stay. We want the young adult to answer the questions, but we always turf mom out during the physical exam. And there's two reasons. The young adult needs to get used to it, but we hammer them with all the questions that they might not answer in front of mom. Drugs, legal or illegal, contraception, et cetera, adherence, because mom might know they're on the pill, but if they're not taking it, they're not adherent. And also that a condom can save lives. So that kind of stuff that, yes, you need contraception, but also you want a barrier so that you're not getting gonorrhea or, heaven forbid, HIV or whatever from somebody else. So we do all that kind of stuff while mom's out of the room. Then when mom, dad, caregiver, whomever, stepmom, grandma, whoever it was that was the long-term caregiver that comes with them, we bring them back in at the end and we say to the young adult before the caregiver comes back, we don't all this stuff will be in a medical record, but it's nobody's business other than yours and the healthcare provider. And if you're not comfortable saying stuff in front of the mom, whoever it is, that's totally fine. And then when the caregiver comes back, we say, okay, we've got the prescriptions. We want you to go up front to book a follow-up. And we look right at the young adult, not at mom, and any other questions or concerns. And then off they go. The parental units or caregivers get used to it. And then eventually they stop coming with the young adult because they realize, okay, it's going okay, et cetera, et cetera. It looks like Jane or Joey are taking their meds, et cetera. So because I think it must be tough as a parent to let go when you've watched this young adult be a child who was sick along the way.
I think it's also, yeah, absolutely hard. Even as a mom of a teenager myself right now, I'm still learning to let go with just routine day-to-day adolescent issues and giving them more independence. And then you layer this health concern that they have, that if they don't take their medications, they may flare. If they start drinking, they may have some other side effects. So it can be quite daunting, and we hear that from our caregivers. And if anything, at those last appointment meetings when we're saying our goodbyes, it's often the parent that's crying, and the child's like, "Okay, thanks, see ya." And they're excited. And then the parents are like just slow to leave because they really don't want to leave. So they definitely need that extra support.
I had to say goodbye to my barber of 5 years the other day, and that was pretty emotional too. So I can't imagine saying goodbye to your doctor would be a difficult relationship to say goodbye to.
Yeah.
That 2022 CRA position paper outlined some more national oriented priorities for transition, but unsurprisingly, policy and implementation haven't really necessarily evolved alongside that. I'm curious kind of how you see the landscape over the next maybe 5, 10 years, or kind of what do we need to do to take all of these insights that you have from your literature and your clinical experience and actually turn that into policy, standard of care, workable guidelines. Of course, recognizing the context that adult rheumatologists sincerely do work in a very different work environment and patient burden than the pediatric space.
Yeah. So I think the position statement was a great first step in just shedding light on the problem and the issues and the challenges that both the pediatric and adult healthcare system are facing with this very vulnerable patient group. Something that is coming up through work under the CRA will be published soon, hopefully, are transition guidelines. And so this will help both the adult rheumatologist in terms of things that they can try, but again, based on the context of their clinic, some things, even as a quality improvement project, that they could attempt to change even one or two things within their flow or their process, as well as from the pediatric side. The other thing, hopefully, is that this tool will help advocate at a government level for resources for the adult rheumatologists, for example, so that they potentially have access to allied health providers, for example, or other individuals who may help with this transition period. And it can also be brought up to hospital administrators to say, you know what, these are Canadian guidelines, and to provide appropriate high quality care, it says you should be doing A, B, or C. And so as a hospital, you may be able to get some support from administration to say, we need more access to clinics or allied health providers or whatever it may be to be able to provide that care to this population. So hopefully with time, so both from these guidelines that will be published and ongoing research to help highlight some unique things that people or clinics can try to do to help improve that transition.
Just before we wrap up, I'm curious if there are any other items that, Michelle, you wanted to touch on that we haven't covered?
Yeah, one thing that hasn't come up is mental health. So I thought, thinking maybe spend a few minutes. So because we're talking about what else is going on in a teenager's life, we know mental health tends to present itself, especially conditions like depression and anxiety, tend to present in those teenage years. We also know that patients diagnosed with chronic rheumatic conditions, and we have evidence to show that the prevalence of mental health is very high as well compared to the healthy population. So this is a time where mental health starts to appear and can clearly also be a barrier to proper transition, and also needs to be addressed in some capacity through their rheumatology team. So it's just something that we need to also keep an eye out on, whether that's through routine screening with a simple questionnaire, or if it's part of your template to remind you to ask about mental health. Janet, as you alluded to, when mom is outside and you have the patient alone, because often patients may not be forthcoming if their parents are in the room, that they're struggling with anxiety or mood symptoms. It's also a good time to bring it out, because as rheumatologists, we may be seeing this patient more often than their family doctor. And so any point of contact with the healthcare system should be an opportunity to identify any potential concerns with their mental health so that appropriate follow-up is ensured. It's not suggesting that we are the ones now who have to treat their anxiety, but if we at least identify concerns, then whether it's suggesting community resources, if you're lucky and you have a social worker, then that's great, or maybe sending a note back to the family doctor to say, hey, there's some concerns. Can you help connect them with the right resources?
I think that's a really good segue to say we want to be holistic with these young adults and the transitioning adolescents, because it's an epidemic. And I think during the pandemic, it was even more obvious. Sad things like more suicide attempts for the youth in Canada and elsewhere, kids cutting more, doing all sorts of stuff that maybe wouldn't have happened without the extra stress and worry going on. And I don't see mental health improving dramatically since the lockdowns all ended, and that's a long time ago now, because they had lost years. They really did. So they lack socialization. There's a lot of fear that wars are going on. The world is going to implode from all the basically the greenhouse effects, et cetera, et cetera. So they have a lot on their plate with so much social media that we didn't even know about greenhouse gases when I was a young adult. It wasn't something that we had heard much about. So I think there's a lot of social media stress for these adolescents, and I think that ending on that we really all should be clued in and cued to help them voice what's really bothering them so that we can help them get what they need.
For sure.
Dr. Michelle Batthish is a pediatric rheumatologist at McMaster Children's Hospital. She is the chair of the Transition Working Group at the Canadian Rheumatology Association. And thank you so much for coming on the podcast. It was a real pleasure.
Thank you for having me, guys. I had a lot of fun.
Great. And thanks for all the research you've done in this area, too. It'll help us to treat the young adults better.
Thank you.
That's it for this episode of Around the Room. We'd like to direct listeners to www.roadtoadultarthritiscare.ca, where you can find transition resources, toolkits, and links for children, parents, and healthcare professionals. For questions, comments, and episode ideas, email us at info@room.ca or tag the CRA social media accounts. Around the Room is produced by David McGuffin of Explore Productions, along with Dr. Dax Rumsey and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for all their hard work. Our theme music was composed by Aaron Fonwell. If you enjoyed your time with us, please give us a rating and review where you listen. It helps us to build our Around the Room community. And please subscribe so you don't miss future episodes. With Janet Pope, I'm Daniel Ennis. Thanks so much for listening.